Okay, urinary, this is chapter 10, 2016, advanced coding book. Let me get my little whoop-de-doo straight. Maybe, okay. Chapter 10, this starts on page 390. 10.1, this is a kidney biopsy. The patient has chronic renal failure. They end up having renal cell adenocarcinoma. You would not code for the hematuria or the proteinuria. If you have CKD, you're going to have proteinuria. If you have renal cell cancer, you're probably going to have the blood in your urine. So don't code for those because they would be symptoms. Make sure you're tracking left or right on your kidney biopsies. Uh-oh, what happened? I don't know what happened. It just froze. Okay, make sure you're tracking your left or right on your kidney biopsies. 10.2, nephrostogram. Bloody discharge or drainage coming from the nephrostomy tube. So this patient has a nephrostomy tube, so your first listed diagnosis is going to be attention to the nephrostomy. That's how you're going to get it's a Z code, and then they end up having a blockage in the ureter, I believe. Maybe. I may have just lied. Oh, you see these, see above. I hate it when they write stuff like that. So they had bloody drainage. The patient describes a situation where the tube may have been retracted while he was sleeping. And then there's so here's the ureter obstruction. I need to underline that. I don't know why I don't already have that. Let me underline that. I could have sworn I read it in here, but why I didn't highlight it, I have no idea. Okay, so there's your ureter obstruction. So that's what's causing all the issues. So do your attention to for your first diagnosis, and then do the ureter obstruction for a second diagnosis. For this gram, or the nephrostogram picture, first you pick your 50,000 level code for the gram, and then it's going to tell you to code, in parentheses, you have to couple it with a radiology code. You have all those urography codes, and this is going to be antegrade. Remember, you can have antegrade or retrograde. Antegrade is just with the flow. Retrograde is against the flow. This, they just put the dye in to see how it flowed. So it's a normal antegrade flow, and that's where they found the obstruction. 2B, they're changing out that nephrostomy tube. So they're changing it out. They did use this is very interesting. Read the black here. They're kind of trying to trick you. You would always have, changing out these tubes, you're always going to have a radiological component to it. So check that, specific to this procedure. Again, your diagnosis code is going to be the attention to the tube. 10.3, nephrectomy, ectomy, removal, nephro meaning kidney. So they are removing that left kidney. They are claiming laparoscopically that they're doing it, so I just kind of make sure I see that lingo. They talk about putting in some ports, so that is a laparoscopic approach and not an open approach. And then they talk about mobilizing the specimen free, so that's my proof that they have actually removed that kidney. So it's a laparoscopic nephrectomy of the left, and it's because of the benign renal cysts, multiple renal cysts. 10.4, this is a extracorporeal shockwave lithotripsy. So this patient has a stone, calculus, a stone. So your CPT code is going to be the ESWL, and then your diagnosis code will be a renal calculus. Track your left and rights. 10.5, they did an excellent job here kind of highlighting the information you need, so you might want to make some notes in your CPT book. This is a they're checking the flow of urine, then they're doing a cystometrogram, then they're also doing an EMG checking for sphincter muscle tone, both urinary sphincter and potentially even rectal pressures too. And then here's the leak point. So at what point would you leak urine? Stress, incontinence, that kind of thing. So you're going to have 4 different CPT codes, and then this is all because of chronic renal failure. Very interesting. This wordy stuff is very good to me. There's just a little bit of it, but it's very, very pertinent to what's going on. 10.6, this is a urethropexy. Pexy is a fixation. Urethro is your urethra. So they are fixating this person's urethra. Because of stress incontinence, it must be folding or it's too mobile, that kind of thing. This patient was already in surgery for the Nephrectomy and the colpo suspension, or the vaginal suspension. So this physician, this moment in time, this physician just went in to do the urethropexy. So you're going to need a 52 modifier for him. He just did a little part of the surgery, so it's a reduced services for him. He didn't have to cut the patient open. He didn't have to anesthetize her. She was already there. He just walked in, did his fixation, and walked out. This is for stress incontinence for his diagnosis code. 10.7, this is a bladder rupture. Patient fell from a ladder, so that immediately tells me that I have to have an injury code specifically to that fall off a ladder, if I can get that much. So this one's very interesting, but from a CPT standpoint, there's just one code. It's just fixing that laceration to the, it talks about he had a fairly long laceration on the part vertical and went fairly close to the superior anterior aspect and continued 2/3 way down. That's a big slice into the bladder. 10.8 is a cystoscopy. They do a bilateral retrograde pyelogram. Very, very common to do that here. So you're going to have your, you're going to have 3 different diagnosis codes. Your cystoscopy code, your retropyelogram code, and then they used fluoroscopic guidance. 10.9, your ureteroscopic stone extraction. This is for a left ureteral calculus. This is when you really got to pay attention to ureteral or urethra. That H can really mess you up. They talk about finding the stone in the left distal ureter. They had to dilate. Dilate the ureter. They visualized the stone. They grabbed it with a basket and withdrew it. And then because they had to dilate that ureter, they decided to put a stent in to keep the ureter open. So you've got actually 4 CPT codes on this too. You have the basket withdrawal of the, or basket extraction of the calculus. You have the stent placement. You have your X-ray for the dilation, and then you have your fluoroscopic guidance. Diagnosis-wise, you've got a calculus, and then you had that obstruction in the ureter that had to be dilated. 10.10. This is op report, stent insertion and TURP. TURP is resection of the prostate, transurethral resection of the prostate. So you're going to have your prostate removal code, you're going to have that indwelling stent, and your fluoroscopic guidance. This particular patient ended up having the prostate cancer secondary to the liver. He had a liver metastasis, so his liver is going to have to be a secondary. And then he also has the ureteral obstruction that I believe this had hydronephrosis. This obstruction was so bad it would back up and the kidneys would get fluid on them. Hydronephrosis. 10-11, mediotomy. So this patient's urethral was stenosed or narrowed, so they had to go in and cut it open so that it would flow well. They did a dilation, and it was for the stricture. That one was pretty easy after everything else. 10-12, this is a resection. Patient has a huge hemangioma, vascular hemangioma on the penis. So they're going in and removing it. Remember, a hemangioma is skin deep, so you're going to have to find your CPT code in the skin. It's not going to be in the urinary because the hemangioma is on the skin. Kind of tricky. 10-13, this is a circumcision, 2-year-old, so don't use the newborn. They're using a dorsal slit technique, and this particular patient has a recurrent yeast infection that keeps coming back. So you'll need a second diagnosis code for that. 10-14, this is testicular biopsies. Pretty straightforward. They're doing biopsies right and left. They're bilateral. 10-15 is a vasectomy. Very, very straightforward. Doesn't really even give you a diagnosis code. So you kind of default to the desire first or encounter for sterilization, which will be a Z code. Hydroceles. This is really good information on hydroceles. So this is an epididymectomy. So they have recurrent left hydrocele, chronic epididymis. So they're removing one of the epididymis, says epididymi. I don't know how you say that. On the left side. Pretty straightforward. This is not such a terrible chapter. 10-17. I'll do this one first. So here's a rectal ultrasound for prostate. They have an elevated PSA, prostate specific antigen is what PSA stands for. So they did some random biopsies. So you're going to code for the biopsies of the prostate, and you're going to code for the ultrasound, the rectal ultrasound. And this is because of an elevated or an abnormal PSA. Now, some of the staging here, I really want you to pay attention to this because you can apply some of this knowledge to any kind of cancer that gets staged, which they all do. That you have a T, you have an N, and an M. And sometimes you'll see it a T1, N1. And that means you have one primary tumor and you have one metastasized tumor or node. Your N stands for your lymph nodes, if it's spread to lymph nodes. Your M stands for any other metastases, bone or something like that. This is really kind of a good thing to kind of get in your mind. Prostate, well, especially from some of the work that I do with HCCs, your Medicare Advantage plan coding for your chronic illnesses. That T1, N1 is very pertinent to us because it allows us to code a secondary cancer, whereas we might not be able to if it wasn't notated how it is. So that's very used in the real world. At 18A, prostatectomy, cancer of the prostate. They're having a bilateral lymph node dissection. Radical retropubic prostatectomy. So those are your keywords right here to find your code. And here you can see bilateral pelvic lymphadenectomy. So that's the radical part of this prostatectomy, is the removal of these lymph nodes. Here is some staging from what we just talked about. This is a lymphadenectomy, prostatectomy, and plastic repair for cancer of the prostate. Here you can see N3, so there's 3 nodes that the primary cancer metastasized to. And then your primary is that adenocarcinoma of the bladder neck and of the cancer, and of the prostate, sorry. So you're going to have 2 primaries and 1 secondary because of how this is. And you may want to go back and reference that. Trying to make it quit. Okay, it stopped. You may have to go back and reference that table. 1020, cryoablation of prostate. Now remember, anytime you have an ablation, that's a destruction. So you may or may not have any tissue go to pathology. If they took a representative biopsy, then they took a biopsy before they destroyed whatever the tissue is. If they didn't, then you won't have anything that goes to pathology. Here they talk about the temperature probes were then placed, so they're obviously either burning it, probably burning it, or freezing it. No, it was cryo, wasn't it? So it's freezing. Yeah, cryo, so it's freezing. Endocrine system. This is a left thyroid mass. Remember, you have a left and a right thyroid. You can have total lobectomy, left or right, and then a total thyroidectomy, which is left and right. So if they're unilateral lobes, you can still have part of the thyroid left. And they just did a total lobectomy, but only of one side, so you still have half your thyroid. So really pay attention to the wording. It can get very, very confusing, and it's very easy to pick the wrong code. This is a left mass. They did a total excision. They did postoperative diagnosis, left thyroid mass, and a right thyroid nodule. So they ended up taking out the whole thing. Whereas coming in, we didn't know that. And here they talk about the left side. Gland was then elevated off this area. Gland was sent to pathologist. Then they saw 2 prominent nodes, so they went to the right side and removed the right side. So you have documentation that they removed both sides or both lobes of the thyroid. And 1022, this is an excision of the right carotid body. Carotid body is within the neck. This one's pretty straightforward, and here's your pathology report. You've got some intraoperative frozen sections. Carotid body mass. You don't have too many codes to choose from. This thyroid, all this endocrine section, thyroid and the carotid body, you have like 1 page in the CPT to pick from. So makes coding these things super, super easy. And then that is it for chapter 10.